Hi, Amita. Just to say hello. We're still waiting for, like everybody to get their Outlook reminder.
Hi, Dick. How are you doing?
Very good. Very good. Thanks for agreeing to give this talk and joining us. As I said, the Outlook is phenomenon is that at exactly 1 p.m. suddenly everybody gets the ding and then we go from 6 people to 30 or 50 or whatever. But so we'll wait for that. But I just wanted to say hello and thanks.
Yeah, absolutely. Thanks for the invitation.
Yeah. Anyway, we'll definitely wait till like 1 minute
sure.
after.
Okay, no problem.
So you can click off again and go back to your emails, etc.
All right, sounds good.
Okay. Hello, Fda. I'm waving, but I have my camera off. Anyway, as I told Amita, we're waiting. Hello, Sandra. Okay, where's that reminder? Hi, everybody. It's exactly 1 o'clock. We will wait another minute before starting for those of you that are joining.
Hi, Dick. Hi, Lysandra.
Hello.
Hey, Madhu. How are you?
Is Amita here?
Yes, she's here.
Yeah, she's here.
Hi, Amita.
Hi, Madhu. How are you doing?
I just wanted to welcome you and thank you for joining us.
Of course. Thank you so much. So nice to see you again.
Dr. Gupta, are you able to share your screen with your PowerPoint presentation?
Yes.
Or? Okay.
Yes, I should be able to do that. Let me get
When
that
the time
ready.
comes. Yeah. Okay. So it's 1:01. So let me introduce first Amita. So I had it right here, Amita. Welcome everybody to our early November seminar, Legal TB Center seminar. So I'm very pleased to welcome Dr. Amita Gupta, who I have a long list of her accomplishments. I'll keep it short because it's in the announcement as well, but faculty chair of the Johns Hopkins India Institute, deputy director of Johns Hopkins Center for Clinical Global Health Education, and professor of medicine, infectious disease, and public health. So I think I'll stop there, Anita, because there's far too much more to read, and we want to give you time to present. But again, it's a real pleasure to have you here, talking about tuberculosis in pregnancy and maybe some of the adverse events that we've been reading about and other safety issues, and an update on this and new stuff. And as always, I'd invite people to mute themselves, but turn their screens on so Amita can at least see a few faces as she's talking and see that we're all awake. And we'll have questions at the end, if that's okay with everyone. And it's definitely easier to send your questions via chat, because then we, in case there's any problems. So I'd encourage people to send questions via chat as we go. Okay, so Amita, I'm turning it over to you.
Great. Well, thank you
And
so much.
hopefully you can share screen and all that. Please.
Yes, I will do that. Thank you, Dick, and thank you, Mother, and many of you who I have the pleasure of reconnecting again with. And I will be presenting on a topic that's near and dear to my heart, and I think something that, like many things in TB, probably all need sort of more understanding, and there's lots of work to be done in the field. So many of you who are budding researchers are already well accomplished but haven't thought about this. Welcome your ideas and suggestions and feedback. So these are just some of my disclosures. So I'll hopefully today in this talk a little bit about the global burden and epidemiology, some of what we know about the impact on maternal child health outcomes, followed by some of the screening data and TB infection sort of testing that's done. What do we know? What do we don't know? And some of the treatment for active disease and infection and some ongoing research. So I think some of you, will have, as if you're clinicians or have been reading literature, you'll see sort of scattered case reports of various presentations of tuberculosis in pregnancy. And here's one such case that had been previously presented at the Union Conference, where from a site in India where the woman presented in her pregnancy at 10 weeks of gestational age and presented with vaginal bleeding and abdominal pain, was diagnosed with pulmonary TB when she was 6 weeks pregnant, and unfortunately had a gestational failure and pregnancy loss. And this here is a published case report from a woman who had extrapulmonary TB with intraocular dissemination and experienced a delay in her diagnosis. She'd presented with diabetes and a positive skin test, had many months of cough. They did not feel a chest x-ray was warranted because of fear of radiation, and it ended up disseminating, and her neonate had to be separated. And they offered formula feeding and INHB6 prophylaxis. This here is a case of a woman who was diagnosed with multi-drug resistant TB initially and had a very prolonged course of treatment for her TB, and had unfortunately courses of incomplete therapy. She went on and off treatment and eventually ended up being treated in France with continued progression of her disease during her pregnancy, and ultimately ended up with very extensively drug-resistant TB and was given bedaquiline and linezolid along with past cycloserine levofloxacin. And she managed to have a healthy delivery, and this was published in Emerging Infectious Diseases, and both her and baby managed to have a good outcome despite this extensively drug-resistant TB. So now I'll go into a little bit about what is the burden of TB in pregnancy. And I think you all know that there's an estimated 10 million new cases of TB each year. Of course, COVID has impacted the detection of TB in the past year. But one of the challenges we face is that while we know 3.2 million women have or females have been diagnosed with TB, we actually don't have any accurate accounting for how many of these women are actually diagnosed during pregnancy or early postpartum. And that's because it's just not collected. So all we have to go by are sort of estimates. And the way some of these estimates are done and some of the thinking around this is that actually incidence of tuberculosis peaks during reproductive age of women, as shown both in studies done in sub-Saharan African women where HIV predominates as a major risk factor, but also in India where HIV is not the major driver. And you can see the peak incidence between the ages of 20 to 40 years of age. And similarly, in a low burning setting of the United States, we also have peak incidence in the US among women between the ages of 25 and 44 as well. So it's not just restricted to high incidence setting where the incidence peaks during reproductive age among women. What another observation that's been made from the epidemiology that's of interest is the fact that it seems that there's a greater proportion of non-pulmonary tuberculosis that's diagnosed in pregnant women. And this is from Epidemiology in the United States, a CDC analysis. where they looked at the number of women diagnosed with TB, and it actually collected the information both for incidence, but also type of TB. They were able to sort of see, well, the incidence was 26 cases per 100,000 pregnancies in the United States. The darker maroon bars show the pulmonary TB versus actually a greater proportion having extrapulmonary TB. And that sort of seems to be something that is where we know extrapulmonary TB has a greater proportion in female sex compared to male, but to see this degree of reversal was sort of a very intriguing finding. So as I mentioned, there's really no national or global reporting of tuberculosis cases in pregnancy. It's not captured in the routine case report forms at a national or international level, at least hasn't been to date. And there have now more recently been attempts where, and I'll speak to that, where just recently some changes have been made to some of the databases. And so what we have is mostly data on individual screening studies, and they're all over the map in terms of the number of cases being diagnosed among those with and without HIV. And similarly for latent infection, most of these are single or a few multi-site studies, but nothing at a national level where we have real collection of the prevalence of disease or infection during pregnancy to sort of collate on a routine basis. This was an attempt to try to get at prevalence of tuberculosis during pregnancy in women with HIV residing in high burden settings. So a systematic review and finding that and these were different screening approaches, some more passive, some more active, some using TST testing. So you have a wide range, but if you look at the whole the summary estimate, it's around 2% of pregnant women are diagnosed with tuberculosis when screened and have HIV. Now, many of these women, this is prior, as you can see, to full extension of antiretroviral therapy. And so as antiretroviral therapy has been scaled up, it appears that some of this incidence is certainly, or I should say, the detection of TB during pregnancy has been less than 2% in some of the more recent studies that have yet to be published, but have been presented at meetings like Union. So this was an actual attempt by a group to take fertility, take TB estimations reported to WHO at the country level, and to try to say what would be our global estimation of TB cases occurring in pregnancy. And so they came up with an estimate of 216,000 cases of TB in pregnancy each year, with the majority of these cases occurring in the African region and the Southeast Asia region. And again, this was based on sort of birth rate, age distribution, population, and case notification. There's been some recent revisiting of the burden. This was presented back in 2019 at the Union conference, where they did an updated estimate and divided it this time to take a look at those diagnosed in pregnancy versus those diagnosed in the postpartum era. And I'll speak to a little bit about that further, but this estimate estimated more around 200,000 women, of which 150,000 were being diagnosed during pregnancy and about 50,000 during the postpartum era, based again on updated estimates that had come from the same type of approach taken previously. But again, these are all estimates. So, you know, we rely on the need for good epidemiology and good reporting. And so what I would say to the team here is we need to do more. We need to do more to get this reported uniformly so that we're not relying on estimates that we know are unfortunately suboptimal. So this is an attempt by the CDC and some of our recent efforts where they recognized that TB is not in pregnancy is not routinely captured. And so we had a group of people put together a proposal and spoke to them and really made the case. And we made a list of variables that we wanted that included pregnancy, gestational age, postpartum, and infant outcomes on the case report form. And here are some of these variables that were considered by the CDC. And of course, unfortunately, they ended up only including gestational age in the form. And so they had this process of trying to decide how to change any surveillance form. And, because it's obviously a very intense process for them to get these data at the state and local level and then compile them nationally, but they use a process. And after all of this was said and done, we ended up with just the question about pregnancy and, just pregnancy, yes, no. Were the women pregnant during their TB diagnosis or not? So that's what's now being collected in the United States on the case report form. So I'll shift gears now to talk a little bit about what do we know about the impact of TB on maternal infant outcomes. So there's been a variety of literature, and some of it dating quite some time ago. And this is not an exhaustive list, but basically from various reviews and case control, case series studies, they've reported on increased maternal complications of things like preeclampsia and eclampsia, being twofold elevated, vaginal bleeding, increased risk of hospitalization, increased risk of miscarriage, and increased maternal mortality when women are diagnosed with tuberculosis in pregnancy. And then in terms of fetal and infant complications, things like increased fetal death, increased low birth weight, lower APGAR, prematurity, small for gestational age, perinatal death. Rarely has congenital TB been reported in the literature. And there's a paper from our group done before antiretroviral was readily available of increased HIV transmission also resulting. Now we know from at least in terms of the pathways by which women who develop tuberculosis, there's sort of three different ways that they might transmit tuberculosis to their neonate or even in utero or to their young infant. And so there's in utero transmission that can occur, and that's thought to be either from hematogenous dissemination via the umbilical vein or aspiration or ingestion of infected amniotic fluid. There's intrapartum transmission that's been described, aspiration or ingestion of infected amniotic fluid or genital secretions during the birthing process, or postpartum when there's inhalation or ingestion of respiratory droplets from mom to infant during breastfeeding, for example. Much less common is via breast milk. It's not thought to be a major source of transmission. So I'll now ask the next area is to really understand, is there a particular time during pregnancy or the postpartum period that increases a risk of TB acquisition or reactivation or severity? So in other words, we know for some diseases like influenza or malaria, where pregnancy modifies either acquisition or severity. And so, there's been interest in the literature to say, how much does this happen because of the immune changes that occur and other changes that occur during pregnancy to increase the condition of tuberculosis? So there's a nice paper that has been subsequently updated in other areas, but this was sort of summarizing some of the pregnancy-related immune changes and physiologic changes that occur during pregnancy, and they certainly change by trimester. So you have changes in innate immunity, changes in cellular immunity, changes in hormone levels as you advance through pregnancy. And as I mentioned, there's certain diseases that get increased in severity. Others that, interestingly enough, improve, things like MS and rheumatoid arthritis. You have increased risk of acquisition of malaria, listeria, and HIV, and increased severity of these other infectious diseases like influenza, et cetera. And so the questions are, does this have any bearing on TB? Well, this here also just illustrating that it's not only the immunologic changes that are relevant during pregnancy, but there are many other changes that occur physiologically that could also change physiology, and particularly when we also think about treatment of disease that are related to changes in fluid, in hepatic metabolism, and renal function. So we will take a look at some of these. And again, this is an area that needs a lot more work. And there's by no means set answers. So there's some who hypothesize that there may indeed be increased risk of acquisition of tuberculosis or reactivation during pregnancy, based on the fact that during pregnancy, there are alterations in CD4 T cell immunology, and in part to really deal with the fact that you're trying to not reject your fetus. You have a tolerance that develops. And so there's also the idea that during pregnancy, you have changes in Th1 suppression, which shifts from Th1 to sort of, and rather Th2 suppression. And then during the postpartum phase, you rebound in your Th2 immune response. And this may actually result in a scenario where you make yourself more relatively immunocompromised during pregnancy, and you may either acquire tuberculosis more readily, or you may reactivate. And what happens is, if you're reactivating, for example, it may not become manifest symptomatically until after you deliver, when you resume your rebound of your Th2 response. And so the relative immune suppression as you advance through pregnancy may make it where you could start to develop less immune control, and then have actual presentation early after delivery. And there's some suggestions, so at least epidemiologically, that can occur. And so what I mean by that is that there was this interesting study done in the UK that found that women who, they looked at actually their primary healthcare database and found that TB incidence was 2 times higher in postpartum women compared to non-pregnant women, with the idea that even when they looked at pregnancy and incident rate ratios in pregnancy compared to 90 days postpartum, they found a nearly 2-fold increase incidence of tuberculosis in the first 90 days post delivery, maybe suggesting that some of these immune changes that have been described with the rapid sort of change that happens during pregnancy and the rapid reversal that happens after delivery could manifest the presence of tuberculosis. I show a study above which actually debates that, and that was where they felt that the data showing that pregnancy was not having any impact on TB reactivation or severity. So I would say that all of this really comes down to needing a lot more information and careful observation, and ideally tying both epidemiology and immunology with careful collection to really understand if this is, if any of this is a reality. This here, we showed early on that we found in an HIV-infected cohort that there was indeed an increase in postpartum TB incidence in women in the pre-ART era. So as I said, we are now embarking on a new study, and hopefully we'll have some data where we are longitudinally following pregnant women, collecting PBMCs, plasma, and their latent status, the latent TB infection status, and actually looking for progression to active disease during pregnancy and the postpartum to first try and answer, one is, are there specific risk factors of pregnancy that are actually related to the risk of acquiring or developing TB during pregnancy? And if so, can we understand what some of those risk factors are immunologically, as well as what are the sort of other contributing factors, such as gestational diabetes, their HIV status, and other such things. There are other groups that have been looking at peripartum risk of TB infection and disease progression. This is work from a Kenya group where they have found that pregnant women with HIV prior to ART rollout had increased conversion of their IGRA from pregnancy to postpartum. and they concluded that indeed that pregnancy was associated with suppression of the IgA immune response, and that there was more likelihood of postpartum conversion. Now, some of that may be due to the immune changes of pregnancy, such that again, the suppression that we described earlier on could be actually infecting the IgA test results. Or it also could be the fact that during this period of susceptibility, they could be acquiring more infection. And so, as I said, this still remains to be sort of determined. What this group did find was that not surprisingly, the IgA conversion and IgA positivity was associated with worse outcomes, both in moms and babies, should they develop either convert or actually develop active disease. So now going to the question that with the initial observations of whether pregnancy impacts performance of screening for active disease or TB infection. So many of you work in the field where you're looking to detect tuberculosis, or you're diagnosing infection using a variety of tests. And as we advance with our understanding of infection, certainly there are newer tests coming down the pike. And for now, though, many of our tests, the tuberculin skin test and the IgA test, rely on host responses to detect infection. And since, as I mentioned, pregnancy has immune changes, it could also be that we are not as well able to detect active disease or infection as a result of these changes of pregnancy. So this here was a look at some of the TB diagnostic sensitivity of the WHO 4-symptom screen for active disease, and compared the different ways to look at symptom screening, smear, expert, and use of LAM. The studies on the right, this was looking at persons with HIV that the WHO had done a systematic review to look at the sensitivity of symptom screen and smear, et cetera, in persons with HIV. The three studies on the left of that, Hoffman, LaCourse, and Gupta, took a look at the WHO symptom screen in particular, and found that there was a lower proportion that were being identified as being positive for the WHO symptom screen, despite being tested positive for tuberculosis when they were screened during pregnancy. So the idea here is that there was a lower sensitivity of the standard WHO symptom screen when they were doing screening in pregnant women populations to rule in disease. More recently, Sylvia LaCourse and her colleagues have actually done a systematic review and taking available look at data that involved a 4-symptom screen of cough, fever, night sweats, and weight loss, and found that in pregnant women living with HIV, the sensitivity of this 4-symptom screen was less than those who were non-pregnant. So looking here in the red box compared to the blue box, you can see here the sensitivity of this 4-symptom screen was as low as 22% based on available published literature, compared to the the systematic review that had been published back in 2011, looking at non-pregnant populations. So the question obviously is how to improve active TB disease screening in pregnant women living with HIV, because they're the highest risk of group to be diagnosed with active TB. And if the symptom screen doesn't work so well, obviously we have to search further. So, it'd be interesting to hear from you about what kind of screening you do in your populations domestically and internationally if you're thinking about TB. I'll say a little bit about the TB infection screening. So in terms of TB infection screening, I think, as all of you know, the goal of TB infection screening, formerly known as latent TB infection, is to identify those who are at highest risk for reactivation disease and to target preventive therapy. And so we know that these are plagued with some of the implementation challenges, especially in low and middle income countries where, having TST and 2 visits for that, are a challenge, how you place the TST. There's also, if you're using IGRA for testing, you have to deal with all the costs and specialty lab and, needing a blood draw to do this. So, those issues aside, there's actually been relatively little attention paid to the performance of TB diagnostics in pregnancy, including for infection. Looking at the two tests that we have available, there's sort of been mixed data. And this slide will need to be updated a little bit because there's now more than just 2 studies that have looked at IGRA in the United States, for example. But this has borne out to be the same result, which found that the test positivity was lower among IGRA in the United States compared to women who also had a tuberculin skin test done. So you were less likely to find an IGRA positive test compared to a TB skin test. In places like India and Kenya and elsewhere, the opposite's been found to be the case, where there has been more IGRA positivity than TST positivity. And interestingly enough, the discordance between the 2 tests seems to be higher, at least in the 2 high incidence settings where it's been looked at. So sort of data are mixed, and why that might be, if some people believe if IGRA positivity is more of a sign of recency of infection, whereas, tuberculin skin testing may be sort of measuring other things like environmental exposure and other such things. And therefore confounded, as well as BCG vaccination, though we sort of know that BCG vaccination should be waning by the time you're in your young adulthood, it still could be confounded in high incidence settings. That's where we usually are doing BCG. So some of these issues of test results and test performance in pregnancy are intriguing. So I'll share some specifics of these data that have looked at comparing the TST testing and the IGRA testing in pregnancy. These are data coming from, as I mentioned, India and Kenya, where the green bars represent the TST and the blue bars represent the IGRA interferon gamma release assay blood test results. And these are the proportion that are positive. And as you can see in each of the scenarios, whether you're looking at HIV infected women or HIV uninfected women, the IGRA proportion positive was higher than the TST positivity. And similarly, interestingly, when you look at the IGRA results more in depth, you find that the mean mitogen and the MTB antigen from the IGRA test are lower in pregnancy compared to the postpartum. So this may in part explain 2 things. One, there's different results coming from each of the tests, depending on which test you use. And also that we may still be further suppressing our IGRA results in pregnancy compared to if you tested a woman and the same woman and she wasn't pregnant as a result of some of the immune changes that occur. These here are data from a multi-country trial that I'll describe later, which also looked at now longitudinal test results of quantiferon specifically, and looking at the same women who were serially tested during the course from their 2nd or 3rd trimester when they entered into the study, and their delivery time point, and then 1 week postpartum. And here, what we found was that the proportion that were positive for the IGRA test, interestingly enough, had a nadir positivity at delivery. So delivery seems to be the time when the immune response to these tests, particularly IGRA, is least likely to be positive. And when you look at 1 year postpartum, you can see the blue bar, there's a slight increase compared to pregnancy. And so when we look specifically at the TB antigens on the right, you can see here when you look at the purple, pay attention to the purple there, and you can see again the nadir at delivery, and then this rebound that occurs by 1 year postpartum, both in the mitogen and the antigen. And so this explains that in part, when you test in the woman's pregnancy course during before delivery, at delivery, or in the postpartum, even as far out as 1 year, you may get a different proportion positive as a result. Okay. Often for clinicians, we also get, when you're thinking about TB infection testing and screening and thinking about offering TB preventive therapy, a lot of times there's a lot of concern over administering a chest X-ray to screen women. We know that if someone's been recently exposed, ideally you do a chest X-ray to make sure they don't have active disease. But often doing chest X-ray testing, whether it's for screening for active disease or even for preparing for TPT, there's a lot of fear of what this might do for women, particularly in low and middle income settings. And so I show this slide just to convince people that the amount of exposure, particularly to the fetus of a chest X-ray, is minimal and considered to be safe. And is made even safer in particular when you're using a proper shield, so that you can safely administer a chest X-ray during pregnancy, whether it be for screening or for either condition, active disease or TPT. So there really has not been any adverse sequelae from a chest X-ray. So now I'm going to ask the question about, does pregnancy impact TB treatment and prevention? And so I'll spend the rest of the sort of time really delving into issues around around this. So as I mentioned earlier, there's a lot of physiologic changes that occur in pregnancy. You have increased body fat, increased total weight, decreased albumin, changes in your hepatic metabolism, such that in particular have increased CYP3A4 that occurs, and as I mentioned, change in renal function. And so it's quite likely that some of the things that happen in pregnancy may in fact change drug levels or change drug metabolism, absorption, elimination. And one of the things that is a particular challenge for addressing tuberculosis in pregnancy is the fact that the vast majority of drugs that are used have really very little to no data specific to pregnancy, other than the reproductive toxicity data that gets generated in animal models when drug companies are working to get their drug to licensure. And uniformly pregnant women have been excluded from clinical trials, phase 1, phase 2, phase 3, and often there's very little done for post-market licensure. So we're left with almost all the drugs that are used for tuberculosis, including ones that have been around since the 1950s and 60s, having this category of which the FDA used to use this nomenclature, and this category C is what most of these drugs all fall under. And this means that animal studies demonstrate a risk, but no human studies have been performed, and potential benefits may outweigh the risks. So this is sort of the where, if we look at now here specifically of drugs like INH and rifampin, they are category C. And other drugs like ethambutol have a little bit better profile of B, and then PZA, which is also category C. And you can also see the other issue related to these drugs in pregnancy is that we still don't have clear data on whether they uniformly cross the placenta and how much do they impact breastfeeding. And so this is really amazing, given that it's been decades with these drugs. And in fact, why does this matter? It matters because there's even a difference in the guidance that exists between the WHO and the CDC, for example, that's specific to pyrazinamide guidance. And so here you can see that in the United States, if you're a woman without HIV and you have been diagnosed with TB, the guidance still recommends avoiding PZA and giving a 9-month regimen, whereas the WHO does not make that recommendation, and in fact says continue with the standard 6 drugs irrespective of whether you're pregnant and irrespective of whether you have HIV. And so I just bring this up because of some of this lack of clarity around how some of these drugs are in terms of the safety. The other area, so now what I wanted to get into is that we are starting to collect a little more data on INH in particular, as well as rifampin, and I'll speak a little bit about what do we know with recent data. So This was a study that the NIH supports to look at pharmacokinetics of TB drugs in pregnancy, and it's done through the Impact Network. And this was presented a little while ago, but they had done a small number of women and done an intensive PK study and looked at whether or not INH exposure was impacted by stage of pregnancy. And as you can say here is that the INH exposure was below the 25th percentile across all stages of pregnancy, as shown in that bottom graph. And so suggesting that indeed the condition of pregnancy, even irrespective of where you were, was impacted by the dynamic changes. And they concluded in this small study that more data was needed on isoniazid and rifampin in pregnancy to make dosing recommendations. Other studies have found that have looked at other first-line drugs, that again, this was another study done and published last year in South Africa, and looked at sparse pharmacokinetics of both INH, ethambutol, and PZA, and concluded that there were very low levels of isoniazid in pregnancy and postpartum that had been observed, but there were no relevant changes with PZA or ethambutol. Again, this was a sparse PK and based on small numbers. This here is a very busy table, but is showing you what do we know with respect to multi-drug resistant TB drugs and pregnancy. And if you can see here, the FDA categorization for Mdr Tb drugs are almost all in the C category, meaning we have very little human data to inform their safety, and D, meaning that there sort of are concerns and they're to be avoided, and X would mean that we're teratogenic. But I think the point here is that most of the drugs we use to treat Mdr Tb, we have very little data of safety relative to PK and toxicity to sort of inform what best to combine. However, we do have obviously case series, and I'll go through a little bit of those where we can sort of look at outcomes, because you don't have choices. When you have a pregnant woman with multi-drug resistant TB who presents to you, you have to come up with the best regimen and try to maximize benefit and minimize harm with minimal data at hand to help you guide the best approach. So you sort of take a look at what the guidelines tell you, and ensure that the drugs that you are going to pull together for your personalized regimen are not associated with teratogenicity or category D, for example, whenever possible, such as the aminoglycosides. So, really, literally, this field of how to treat Mdr Tb in pregnancy is based on published case reports and case series, where many have used individualized treatment approaches or followed their public health approach of using at least 5 active agents, deferring the injectable to after delivery, and often not recommending breastfeeding, or if they do, they just say there's no data available. So, when they're counseling women, and the regimens have all been variable, and the outcomes, certainly from the case series that have been published, suggest that treatment success is possible. I'll go through one of the more recent case series, which is the largest case series that was recently published by Maureen Loveday, from looking at Mdr Tb and rifampin resistant TB in South Africa. She had performed a cohort analysis and then did a record review to look at outcomes of women diagnosed with multi-drug resistant and rifampin resistant TB in pregnancy, and had a case series of 108 women, a quarter of whom had, fairly extensively drug resistant TB, 81% of whom were HIV infected. And you can see when they started their TB drug initiation, most of whom started in the 3rd trimester, but there were certainly those who started earlier. And you can see how the challenges, these were all individualized regimens with a host of drugs shown here on the right for what were used in various combinations to treat Mdr Tb. And what did she find? She found that a third of these women had an unfavorable maternal TB treatment outcome. And specifically, when she then looked at pregnancy outcomes, nearly half had an unfavorable pregnancy outcome. That included things like fetal deaths, preterm delivery, low birth weight. And then in terms of the infant outcomes among those that were live born, there was 16% that had an unfavorable infant outcome. She specifically then did a sub-study to look at bedaquiline, one of the newer agents, and found that the use of bedaquiline appeared to have a more favorable treatment outcome in these women, with the exception of low birth weight, where bedaquiline was seemed to be associated with increased risk of low birth weight when used compared to not using it. I'll just say a quick detour about breastfeeding during TB treatment and pregnancy. Generally, the guidelines suggest that breastfeeding are encouraged once a woman's non-infectious, if she's on first-line agents, and that the concentration of TB meds in breast milk typically are found only in small concentrations that are thought to be non-toxic to the infant, and certainly not effective for treatment, either for prevention or for treatment for the infant. So that's sort of the general guidance that exists for breastfeeding during TB treatment and pregnancy. I'll spend the last few minutes really focusing on some of the safety concerns or some of the studies that we've done more recently for treating, rather giving preventive therapy for infection or for prevention of TB disease and initiating TPT in pregnancy. So, doing TPT in pregnancy is not actually a completely new phenomenon. So I share this report from 1959 and that was published to take really a look at how best to prevent babies from getting TB disease among women who had TB. And this here, they used actually INH preventive therapy during this time in a Durban, South African population. And it was sort of a small case series to sort of describe their initial experience of this. So in terms of, I'll skip over this here and just say that one of the reasons for TPT and the concerns, and this is based on historical literature, is that there's this concern of hepatotoxicity that might be increased with use of isoniazid in pregnancy. This is based on some of the old literature from the 1980s and the US Public Health Service, where they had treated more than 3,600 women with INH. And specifically in that study, 5 of the women who were pregnant developed hepatitis and 2 died. There was a different study from California that found that 20 of the INH-associated deaths, 4 of them had initiated INH in pregnancy. And so there was this early signal saying perhaps pregnancy is associated with increase of hepatotoxicity and mortality. However, subsequent to sort of those early reports, there have been these IPT implementation studies done over the last 2 decades, and specifically, especially in women with HIV, trying to prevent tuberculosis. And there did not seem to be that type of signal appreciated. I will say, however, that many of these studies were not granular enough to, or sort of designed with the idea of really looking for safety of IPT in pregnancy. And today, currently, what we have as our guidelines are differ based on burden of risk of when to start TPT. So in the United States, if you're in a low burden setting and you don't have HIV, our current recommendation, if you are either skin test positive because you've been screened during pregnancy, is to actually defer initiation of TPT until after you've delivered, usually until the 2nd or 3rd month of pregnancy. But if you have a high risk factor, either been a recent contact or a person living with HIV, then the recommendation is to initiate TPT with isoniazid or other regimens as relevant based on literature, and I'll go through some of that. At the time of this this guideline, we didn't have data on the short course 3-HP isoniazid rifapentine combination, the 3-HP regimen, and we certainly don't yet have any information on the 1-HP regimen. And it's been less well studied to sort of look at the 4 months of rifampin that Dick Menzies studied in terms of specific information for pregnancy. In high burden settings, if you take a look here, what the WHO recommends is a 6-month regimen of isoniazid, or alternatively, looking at rifampin for 4 months, but not necessarily based on data that's specific to pregnancy. And then similarly, there's only until recently sort of more recommendations that have come for treatment of all women with HIV, don't have active TB, to initiate if they have evidence of HIV to start their TPT during pregnancy. And I'll speak to why this may be something to sort of consider and look into further based on some of our data of safety around isoniazid in pregnancy. So this here gets at the fact that we've had many TB trials for prevention in both HIV infected and uninfected individuals. In fact, 13 or more, and all have excluded pregnant women from entry into the trials. And so this sort of creates a challenge for us to really be able to know how best to optimally manage pregnant women. And there's been now many groups and efforts to really provide a scientific rationale for including pregnant women into clinical trials of TB therapeutics, whether they be for treatment or prevention. And I won't go through all the reasons, but there's both ethical, scientific, and need to really, this is the best time to study safety for advancing our understanding of TB in pregnancy. And we ourselves are one of the many groups who've come together and made statements about this by expert consensus. Some of the things that we've generated are really when is good timing of including pregnant women, particularly for phase 3 multi-drug resistant TB trials. Then, of course, ensuring that women who become pregnant during the course of a trial be offered a consent statement to either continue or to stop. And if they decide to stop, then to, regardless, in both scenarios, collect relevant data on their pregnancy outcome so we can adequately study relationships between exposure and outcome. And this, believe it or not, is still not sort of set in stone. We don't have a registry that exists the way we do for HIV to really look at antiretroviral therapy. We don't have a TB pregnancy registry to collect exposure data and outcome data uniformly across trials. So what we're left with is to look at pregnancy and infant outcomes, doing sort of secondary analyses on the trials that have been done to date. And so I'm just giving you some of the examples here. These are 3 trials which had looked at TB prevention in either HIV or persons without HIV, and then did small post hoc analyses to look and see if there was any association between TPT and pregnancy outcome. And actually, it seemed that, at least based on these small numbers, the TB prevention trial at the top had 25 women who became pregnant on INH and 10 who chose to continue, and they did not observe any toxicities based on N of 10. In the I-Adhere trial, they had congenital anomalies that were similar to both arms, whether they be INH or 3HP, and did not find any difference in fetal loss between the 2 arms. And then Batusa similarly did not find any associations in the small number of women that they studied, the 103 women, where they were comparing 6 months of INH to 36 months of INH. So that was sort of where we started with our background. So I'll skip over this slide here, that is just again the statement. So then why I became really interested, I I had been studying tuberculosis in pregnancy when we were doing an HIV prevention trial, and I had noted that many of the women in India were developing TB, and had to look to see what we could do to sort of try to prevent it, not just prevent HIV transmission, but also prevent tuberculosis from developing during pregnancy. And so from those early observations, we actually designed a trial called Impact P1078. And it was a phase 4 randomized trial to evaluate the safety of INH initiation given in pregnancy versus waiting until 3 months postpartum to see if we could look at the safety and effectiveness of INH in a multi-country setting. And so this here is just the schema of women that got enrolled into this trial. We enrolled women between the 14 and 34 weeks of gestation. We randomized them, and it was a placebo-controlled trial. They either received their INH while they were pregnant and got B6 and a multivitamin, or they were deferred to receiving it at 3 months postpartum. And both groups were followed until 48 weeks postpartum, and we collected data on toxicity and outcomes. And what we found was that the safety of antenatal INH was non-inferior to postpartum in terms of maternal events. We found increased hepatotoxicity in the women who started in actually both arms during the postpartum period. And we also, to our surprise, found that starting isoniazid during pregnancy was associated with increased adverse pregnancy outcomes. Specifically, there was more fetal demise and more low birth weight. And it seemed that there was a signal more so for women started in their second trimester compared to their third trimester. So these here just show specifically, this was a trial we published in New England Journal back in 2019, that in terms of most of the events, there was no comparison that was statistically significant in terms of looking at maternal adverse events or infant adverse events, maternal death or infant death, and we overall had low incidence of both. However, as I said, that the composite pregnancy outcomes were more likely to occur in the isoniazid immediate arm shown in blue compared to the orange bars, which was the INH starting at 3 months postpartum. And as I mentioned, these were more due to more fetal demises and more low birth weight. So this had us take a look at the data in a greater way. And we just published results looking at these outcomes again after adjusting for all the other potential confounders, including things like twin gestation, smoking, and other things that might drive adverse pregnancy outcomes, hypertension in pregnancy, et cetera, and still found that the INH use when initiated in pregnancy compared to postpartum was associated with an increased risk that was statistically significant around, if you look at the first line here, the fetal demise, preterm birth, low birth weight, and congenital anomaly with adjustment was still 63% higher. And this then looking even at the individual outcomes was significant for fetal demise and low birth weight. In the interest of time, I see that we have only 10 minutes. I won't go through all the findings from the trial, but we have been looking at things like hepatotoxicity and the like. So I'm going to skip over these slides and talk a little bit about the fact that the WHO has done now a systematic review looking at the safety of isoniazid preventive therapy in pregnancy. And the basis of their analysis has really taken our trial and then looked at cohort studies or secondary analyses. And so there are no other clinical trials that have specifically looked at isoniazid initiation in pregnancy. So their systematic review resulted in this sort of inconsistent associations. So they specifically took a look and said, we found inconsistent associations between isoniazid preventive therapy and adverse pregnancy outcomes. Considering the grave consequences of active TB in pregnancy, current evidence does not support deferral of IPT until postpartum, and more research is needed. And so I will say that some of these analyses that have been done, so for example, The Salazar-Austin study was based on a very small number, was not a randomized trial, and there's likely confounding by indication where women who were healthier were offered isoniazid compared to women who were not. This study had found a benefit of the INH prevention, but the study design was really not designed to look for safety events. The Taylor study I already mentioned, which was the Batusa study, looked again, was not designed to look at safety, but at that study in a small, about 100 women, did not find any clear signal. So this is where we're left with confusing data. We more recently, just last year, as a result of this, took a look at another trial that had INH in its arm to really more carefully look at isoniazid exposure. And I presented these data earlier this year at CROI. And what we did was we had a big clinical trial that had one arm with INH and then other arm with 1 month of isoniazid and rifapentine. And we analyzed all the pregnancy outcomes in the INH arm because there was really only one pregnancy that occurred in the 1HP arm, so we couldn't really include that arm. So we looked at those exposed to INH and those not. And this would have been first trimester exposure. And we found that actually there was increased fetal demise, spontaneous abortion that was nearly 2-fold higher in the women who were exposed to isoniazid in their first trimester compared to those who were not exposed, i.e. they became pregnant well after the INH treatment was completed. And so we're left again with many questions. So I'll leave that here to say that we need data for shorter regimens. We need data to really look at this INH safety signal and sort of come to sort of really understand, is this a true signal? I certainly am concerned based on the sort of 2 analyses, but one from a randomized trial that was designed to specifically look at the issue, and one that this more recent analysis, which is why we're embarking now on a systematic review of looking at INH in pregnancy and looking at all the randomized trials. And I've reached out to anyone who's done an INH preventive therapy trial and has any data relevant to pregnancy to take a look to see if we can answer this question more formatively and definitively. So I've presented a lot of information, and the key points to take home here are there's peak incidence of tuberculosis in pregnancy. We have impacts of pregnancy and the immune changes that result in less sensitive screening by symptoms, by use of our tests that diagnose TB infection, because these are host-directed tests, and they seem to be less sensitive as a result of the immune changes of pregnancy. And we still have a lot of questions about best and safest and most effective regimens for treatment of both drug-susceptible, drug-resistant TB, as well as how best to manage TB preventive therapy in pregnancy. So I'll stop there and open ourselves up for questions.
Great, thanks, Amita. Right, so indeed, we're right at 2 o'clock. So if anybody, I did send a few questions through the chat, but if anybody else has questions, please send them now, or just put up your hand. Or I suppose unmute yourself and start talking. That was another option. Because otherwise, very quickly, Amita, first of all, thanks again, really great talk, terrific overview. As you said, a lot of information there. I'm still trying to absorb even 10% of it. But what about 4R? You mentioned 4R safety. It's recommended as an alternative. Of course, you know, the hometown advantage, let's say, the hometown favorite is 4R. Are you have plans to evaluate that in pregnancy?
Well, there is, you know, I'm not aware of any clinical trial that's formally evaluated it. It certainly has been used based on expert consensus. And I think that's taking into account, you know, what's known about rifampin use from, you know, treatment trials and the fact that it's offered and there doesn't seem to be sort of, at least based on the case series, any clear concern. Other than there's some reports that rifampin may be associated with increased bleeding risk. But again, that has not been fully borne out. So this is where, I wish your trial had included an arm of pregnant women, and we could have actually answered that. You could have answered that question more definitively. So it's there in the recommendation as a possible alternative, but it's not something that's done routinely anywhere that I'm aware of.
Okay, thanks. Any other? I did also note that the quantiferin results during pregnancy, very interesting results, that it was the proportion of indeterminate that really went up during pregnancy, especially at delivery. That was actually your biggest signal, and then went down postpartum. Accounting, if you account for that, that really explains the drop in positivity, if you will.
Yes, and I think that the difference in discordance, as you rightfully mentioned. So it seems like that the delivery time point is when the most changes are occurring. It's particularly when the most sort of dynamic host responses are occurring, and that therefore the increased indeterminate results have been observed. That, as well as, I will say, there are the studies which, not only from indeterminate, but actually the proportion positive. So there's proportion indeterminate and proportion positive that are changed and most exacerbated during delivery. There's a question from Jonathan.
Jonathan, yeah.
Yeah, thanks for the talk. I found I guess the 1 or 2 slides you presented on the sensitivity of the WHO symptom screen during pregnancy quite interesting. So I'm involved in a few studies in Benin where they're screening people, like pregnant women, prior to delivery, and then again in the postpartum period in a separate cohort.
Mm-hmm.
And the symptoms that they screen for, according to guidelines, they don't do the 4-symptom screen. It's just cough longer than 2 weeks, and that's the kind of flag to go and do expert. We found about 1 in 2,000 pregnant women were positive, which is no different than the national incidence. It was like pretty equivalent. And then in a similar postpartum study found no women with TB, which we found quite surprising. I guess your data there of the reduced sensitivity during pregnancy explains that. But my question, I guess, is how do we improve screening for TB during pregnancy if the sensitivity of the symptom screen is low? Guidelines already try and simplify it. Yeah, I'm just.
And is
we're
this
trying
in
to
a low
struggle.
Incidence setting, or
This
in
is
a high?
Benin. I mean, Benin's about like
Benin.
50 to 60 per 100,000, and that's
Okay.
about what we found.
Yeah.
Just about, yeah.
Yeah, so it's one of those things. Again, remember the numbers compared to the annual numbers diagnosed of 10 million. I mean, the numbers estimated, if we sort of believe the most recent estimate of 150,000 cases. But I think that you have to screen a lot of women to find an individual positive case, which is a good thing for the most part. So it's not a I would say it's a population where you want to find an active case whenever possible. I think that the optimal screening test will require a much larger sample size than, because of the incidence that is reported. And so, I think it's one of those where we can do particularly sort of have impact on TB and incidence in reproductive age women is the rollout of TPT, a preventive therapy, rather than just searching for active TB cases, which of course should be done. And I would say I don't have the answer on what's the best screening algorithm, because I don't think we have, I think you do the cough and you can do the 4-symptom screen, recognizing that there's reduced and then some groups have said that adding the question about have they had anyone else exposed or diagnosed that they know of. So the epidemiology question of, anyone in your household or anyone in your community, do you know anyone who's recently been diagnosed, helps to increase your pretest probability, no surprise. So using that, not just the symptom screen by itself. And then I would say that, the emphasis should really be on using the time when women come in for care as the time to roll out preventive therapy if we can come up with something that's safe and isn't associated with increased adverse pregnancy outcomes.
Great, thank you. That's helpful. Yeah, that's exactly their plan is not TPT, is just to leverage routine health interactions to increase case finding. Anyways, thanks for the response. Appreciate it.
Mm-hmm.
Thank you, Amita. I know we are over time and Dick had to jump off to another call. So grateful for your time, but also your work in this very important and understudied area. So little is known despite hundreds of years of TB research. So really grateful for your work in this area.
Well, thank you. And I'm sorry, I think I presented a lot of stuff, so I'll happily share the slides. And you know, if there are any questions, by all means, send them my way, and I'd be happy to answer them by email. So thanks.
Thank you. Stay safe.
Bye
Happy
bye.
Thanksgiving coming up. Bye, everyone.